All right, good afternoon, everyone. I'm going to call this meeting of the Health, Finance, and Policy Committee to order. If folks are watching, they know that we're pushed back about a half hour from our, or I should say a half hour from our usual start time by the delay on the floor. So we're going to go today from 3:30, until 5 o'clock. So that is the plan. All right, Ms. Niederhofer, if you would please take the roll.
Chair Liebling.
Present.
Vice Chair Huot.
Present.
Lead Schumacher.
Schumacher, present.
Representative Ackland. Representative Ackland. Representative Backer.
Backer, present.
Representative Bonner.
Present.
Representative Bierman.
Present.
Representative Bolden.
Present.
Representative Dameth.
Present.
Representative Freiberg.
Present.
Representative Grunhagen.
Present.
Representative Keel.
Present.
Representative Morrison.
Morrison, present.
Representative Munson.
Present.
Representative Pryor.
Present.
Representative Quam.
Present.
Representative Ryer.
Present.
Representative Schultz.
Present.
Representative Wolgamott.
Wolgamott, present.
Madam Chair, a quorum is present.
All right, thank you very much, Ms. Niederhofer. Okay, next order of business is to approve the minutes of March 9th. Is there a motion to approve the minutes?
Madam Chair, so moved.
Thank you, Representative Huot. Representative Huot moves approval of the minutes of March 9th. Is there any discussion to the minutes? All right, seeing none, please unmute yourselves. All those in favor of approval of the minutes of March 9th, please say aye.
Aye.
Any opposed? The motion prevails. The minutes are approved. Thank you. The first
Madam
bill.
Chair, can you hear me?
Yes, I can, Representative Ackland. I
I'm
can
sorry.
see you're on your phone or something, but you're fine.
My computer is not working, so I'm going to try this on my phone today for the first time. So thank you. I'm
All
here.
right. All right.
Okay.
Thank you. You might need to mute yourself on your phone. I think that's *6 feature. You manage, so we're good. Thank you. Or maybe our staff muted you. Okay, we're going to start here with Representative Schultz's bill, House File 1002. So Representative Schultz, your bill, the motion here is to have the bill laid over. And I should say it's 1002, the first engrossment to be laid over for possible inclusion in the finance bill. And Representative Schultz, you have an amendment, and I think, did you want to take that up right away?
Yes, Chair Liebling.
Okay. So Representative Schultz is moving the A1 amendment, and I think it just takes out a section. So all those in favor of the A1 amendment, please say aye.
Aye. Aye.
Any opposed? Motion prevails. The amendment is adopted. Okay, Representative Schultz, please go ahead and present your bill.
Thank you, Chair Liebling. So House File 1002 puts in state statute protections in case the Affordable Care Act is repealed. There's currently a case that was heard in November at the Supreme Court, the U.S. Supreme Court, and they are deliberating, and the decision may come out later this spring. So this would ensure that we put in protections so people can keep their affordable health insurance that was provided through the Affordable Care Act. And this builds on work that was done in past sessions by Representative Richardson and former Representative Cantrell. So what it does, it puts in a 3-month grace period for unpaid premiums in Minnesota statute. It puts a 90-day limit on waiting periods that group plans may impose before coverage starts in Minnesota. It makes co-payments and co-insurance and deductibles for HMOs consistent with state and federal law. It has preventive items and services that are covered without cost sharing. And we relied on the Department of Commerce to determine these items. It removes the ACA reference and language that allows individuals to remain on their parents' plans up to age 26. Out-of-pocket limits, in addition to eliminating annual and lifetime maximums for coverage, the ACA limits out-of-pocket expenses, and this bill had the Department of Commerce determine this maximum annual out-of-pocket limit, which would be applicable to our individual health plans and small group health plans. And then already in, it also has essential health benefits that are covered in Minnesota law. It puts the metal levels that are into Minnesota law. And we already have in state statute language regarding risk pooling and gender-based pricing. So that's not necessary to put in this bill to ensure that we continue coverage similar to what's currently offered through the Affordable Care Act in federal statute. So members, that's basically the bulk of the bill. I urge your support for it so we can ensure that people are not kicked off coverage in case the Supreme Court has a ruling that affects the Affordable Care Act, and that we can protect access to vital health care that so many families in Minnesota rely on. So thank you, Chair Liebling, for hearing the bill.
All right, thank you very much, Chair Schultz. So we do have one testifier, and then we can take questions and have discussion. Mr. Andreessen, welcome to the committee.
Thank you, Madam Chair, members of the committee. My name is Dan Andreessen with the Minnesota Council of Health Plans. We do appreciate the dialogue we've had so far with Representative Schultz on this bill and is committed to continuing these dialogues. Something we just want to avoid is any conflict with federal law, and also be mindful of any operational challenges once we blink off one law and try to turn on another one without significant planning. If House File 1002 is intended to replace provisions in the ACA if repealed, we would urge that the language exactly match up with that in federal law. Otherwise, we're going to have state law conflicting with federal law. We're still evaluating the language in the bill versus the ACA, but we have found one discrepancy in the language regarding the premium grace periods in Section 4, Subdivision 2A. Under the ACA, those receiving advanced premium tax credits through the exchange have a 90-day grace period, while those not receiving the tax credits have a 30-day period. The language in House File 1002 extends this 90-day grace period to everyone in the exchange and also the entire small group market and those purchasing off the exchange. So we would urge further discussion if the intent is to go beyond the federal laws that our carriers are currently complying with within the ACA. We'd also recommend working on an effective date for these changes. It may be best to have a date that's tied to the repeal of the ACA, but also make sure that these changes aren't happening within the middle of a plan year. Like I said, we continue to meet with Representative Schultz on this bill, and I'm happy to work with her as the bill's laid over. Thank you.
All right, thank you, Mr. Andreessen. Representative Schultz, did you want to respond to any of that before we go to any questions?
Chair Liebling, the language isn't exactly, because we're strengthening the language and making it more consistent with that grace period. So it doesn't depend, so it's more consistent regardless of whether you receive tax credits or not. So that was intentional.
Okay. All right, we're going to go to Representative Gruenhagen.
Oh, thank you, Madam Chair. Yeah, I have concerns about the bill also. You know, the ACA has seriously damaged the individual market and small group market here in the state of Minnesota. One of the things to keep in mind, Representative Schultz, is that the private health insurance market has bailed out the losses of government reimbursement programs from Medicaid and Medicare for over 40 years. And that's what's kept the government programs afloat, because they've cost shifted to the private health insurance market. When we damage the private health insurance market, you lose the ability to carry those losses over. And as the Minneapolis Tribune reported a couple of years ago, we have hospitals on the brink of going out of business if you go to complete government reimbursement. So this bill takes us completely in the wrong direction. We need to reform the private health insurance market in a way that grows the private health insurance so that proper reimbursement can be paid to our medical providers. You're going to damage one of the best healthcare systems in the world by promoting this. So just for food for thought, okay? I don't like the bill. I'm going to work with the Senate to stop it. Thank you.
Representative Schultz, did you want to respond?
We don't have the best health system in the world for everyone in our country, and that's the problem we need to address. So we have a very expensive healthcare system. We have healthcare costs that grow disproportionately to normal inflation. So we have a lot of work to do, and I really would enjoy working with you, Representative Gruenhagen, on figuring out reforms that will work. The Affordable Care Act, significant reliance on private markets. And so if we have problems, we need to look at our private markets as well. What it really is doing is it's helping subsidize low-income families, which I hope you would support.
Madam Chair?
Representative Gruenhagen?
Yeah, hey, appreciate that, Representative Schultz. But look at the track record of the ACA. It's skyrocketing deductibles, skyrocketing premium. And in fact, in some cases with the essential benefit set, it left things like PANDAS, which used to be covered under the MCHA, not covered. So it's done more damage, even in terms of healthcare, to our system. And to reinforce it into our system, blocking all other types of reform, is the wrong direction to go. Thank you, Madam Chair.
All right, Representative Ryer.
Madam Chair, thank you, Representative Schultz, for bringing this forward, because I will tell you true, one of the things I lose sleep over is this upcoming Supreme Court decision. I watched in my years at Blue Cross, and then since, I watched the uninsured rate go down point by point in Minnesota and across the country, especially where there was less resistance to it. I also remember clearly that technical corrections that would be typical on a large bill of this type did not get through in Congress because of partisanship. So to me, to say to all of the people who are relying on this now and who value the access that the Affordable Care Act brings, that we're going to protect it, at least here in Minnesota, I think is a huge step, and I think it's the right step, and I thank you for bringing it forward.
All right, thank you, Representative Ryer. Representative Quam.
Thank you, Madam Chair. And a few of us were around before the PPACA. People keep dropping off. It originally was patient protection, and they abbreviate it because I think some of the PP got lost. Minnesota led the nation in insured. We also, I believe it was half to a third, qualified for programs but didn't sign up of the uninsured. And so I think Minnesota had a very good program to start with. I have concerns because many people lost their networks, their accessibility to the doctors they had, and shrinking of networks in Minnesota over the last decade has been an issue, at least in greater Minnesota, if it's not also in the metro. And frankly, I think we in Minnesota did a better job than the nation. And I think we could do a better job than copying this. And I think working together, we would be more successful, and we'd fix some of the flaws that come from, the national program. And I would prefer that approach. I understand what a lot of people are scared, but I think we're up to the task of actually providing Minnesotans, once again, the leader in healthcare network option and improved on costs. So I think there is a better way than clinging to something that was originating in DC instead of Minnesota. Thank you, Madam Chair.
All right, Representative Bierman, and then we're going to wrap up. Representative Bierman.
Thank you, Madam Chair. just under the wire there. Thank you for recognizing me. Representative Schultz, thank you for bringing the bill forward. You know, I look at the healthcare industry as a small business owner who purchased a business in 1993, and I have seen the cost of healthcare for my employees go in one direction, steadily up. And while it goes up, the coverage goes steadily down. And I've had to push more costs onto my employees to the point where they seem like they can't afford to go to the doctor anymore. So the access for healthcare has been denied to people who even have insurance when prices are so out of whack in this system. So I thank you for bringing the bill forward and doing what you can. I do have a question. There's, you know, the fact of what was said about the Affordable Care Act being something that has ruined healthcare. As I said, prices went up well before the Affordable Care Act, and President Obama has been out of office now we're going on 5 years. So we kind of have to get beyond, you know, what didn't happen in the last 4 years when, you know, if you want to talk about promises, we were supposed to get a healthcare system that was easier, cheaper, and everybody would be covered. Somehow that didn't materialize in the last 4 years. So I appreciate you bringing the bill forward. We have to be prepared for what comes next. And the question I have is, what about pre-existing conditions? One of the most popular things about the ACA Act. How is that addressed in this bill, if at all?
Thank you, Representative Bierman. Representative Schultz.
I didn't hear his question. I didn't hear Representative Bierman's question.
His question was about pre-existing conditions, whether that piece is addressed in the bill.
Yes, it is addressed. So that means that they wouldn't be able to charge higher premiums if you had pre-existing conditions. It wouldn't be based on your health status.
All right, Representative Bierman. Okay, so I'm going to give Representative Schultz the last word. I just want to say that I'm glad Representative Bierman mentioned that. You know, it's easy to be against stuff. It's hard to find things that actually work. And, you know, I was never a great fan of the ACA because it relies on private insurance. So I view it as a real middle ground. But in fact, it has brought a lot of protections to people. And the idea that it would be just yanked away, which is something that the Trump administration, frankly, Republicans, as long as I've since this came into being in this legislature, Republicans have been against it, of course. And there's never been a real alternative. That's the problem. So I don't think, probably none of us here think this is the be all and end all of how to handle healthcare, certainly, but it sure is a darn sight better than what we had. And it's a darn sight better than if the Supreme Court just took it all away. And where would we be? So I think this is a really important step and appreciate that Representative Schultz has brought this forward. Representative Schultz, final word.
Thank you, Chair Liebling and members. I urge your support. Minnesotans like to be prepared. So we don't know what the outcome will be of the SCOTUS case, but we need to be prepared and this will prepare us. And you know, most people are not affected by the ACA, even though it expanded coverage to more than 20 million people nationwide, which was the goal, was to increase access to health insurance. Most people get their insurance through their employer, but even people who work full-time, they really can't afford their premiums through their employer anymore either. They can't afford the high deductibles and the premiums are high. So we have a big problem in Minnesota and this country that we need to continue to work on. And you know, Republicans, they have tried to repeal the ACA, I believe 58 times. And even when they had control in both the US House and the Senate with former President Trump in charge, they failed to repeal it. I am still waiting to hear what some solutions are from my Republican colleagues. But Representative Plum, I hope you can support House File 11 because that is another alternative to moving forward on addressing healthcare costs and affordability in the state of Minnesota. I appreciate you hearing the bill, Representative Lee. Thank you.
All right, so House File 1002, first engrossment as amended is laid over for possible inclusion in the finance bill. So now the next order of business here is we're going to have House File 520, and this was heard in the Preventive Health Division. So we need to move the division report. Representative Freiberg, Chair Freiberg, would you like to move the Preventive Health Division report on House File 520?
Yes, thank you, Madam Chair. I will move the division report.
Great. All right. Is there any discussion to the division report to bring it before the committee? All right. Seeing none, all in favor of the moving the division report, please say aye.
Aye.
Any opposed? Motion prevails. The division report is adopted. And now Representative Morrison, whose bill this is going to move that House File 520 be laid over for possible inclusion in the finance bill. And just to note that this bill, since it was a division report, you all know that it was heard in the division. It received a full hearing in the division. So we could certainly have a little bit of discussion here, but hopefully we don't have to redo the entire discussion from the division. And Representative Morrison, I understand there is an A1 amendment. Did you want to move that first?
Yes, Madam Chair, I would like to move the A1 amendment.
All right, so Representative Morrison is moving the A1 amendment to get the bill in the order in which she'd like to have it discussed here. And did you want to just briefly describe that, Representative Morrison? I think it just reinstates some language, right?
Madam Chair, members, this corrects a drafting error, so it does reinstate a clause that was inadvertently deleted.
Okay, so all in favor of the A1 amendment, please say aye.
Aye.
Aye. Any opposed? The motion prevails. Okay, thank you. The motion prevails. So Representative Morrison to 520 as amended.
Thank you, Madam Chair and members. I am pleased to present House File 520, a bill that would protect and expand access to contraception in Minnesota. Birth control is essential to the health and well-being of Minnesotans. Nearly 9 in 10 women of reproductive age will use birth control at some point in their lives, many of them for reasons beyond planning a pregnancy, such as treating endometriosis or migraines. Birth control allows women to plan and space their pregnancies and reduces maternal mortality. Unlike most developed countries, the maternal mortality rate in the United States is increasing, and Black women are most at risk of dying during or from childbirth. According to a Johns Hopkins study, increasing contraceptive access is one of the most effective ways to reduce maternal mortality. To ensure that Minnesotans can plan their families and their futures by accessing the birth control method that is right for them, regardless of cost and free of unnecessary insurance barriers, House File 520 does 2 things. 1, it puts the Affordable Care Act requirement that insurance plans cover FDA-approved categories of contraception at no out-of-pocket cost into our state law. And secondly, it allows Minnesotans to receive up to a 12-month supply of birth control at a time covered by insurance. 16 states have already codified the ACA birth control rule into their state law and require their state-regulated health insurance plans to cover a full range of birth control at no cost. 20 states have enacted laws that allow patients to receive an extended supply of birth control at once. With the ACA again before the United States Supreme Court, now is the time to pass this bill and make sure that Minnesotans can retain this important health coverage. Birth control is basic preventive health care. Millions of Minnesotans, including thousands of all of our constituents, members of our families, and many of us in the room today, rely on birth control to plan and space our pregnancies, control underlying health conditions, attend college, and progress in our jobs. I urge you to join me in supporting this common sense bill that will help protect and expand access to contraception in Minnesota.
All right, thank you, Representative Morrison. I understand we do have a testifier.
Yes, Madam Chair. I think Dr. Elizabeth Slagle is with us.
All right, well, welcome, Dr. Slagle. And if we could, we did have a full hearing in the division, so if we could just ask you to please be brief, but we're glad to have you with us today. And welcome, if you could just give us your full name and any affiliation you have, and please proceed.
Thank you. Thank you, Madam Chair and members of the committee. My name is Dr. Elizabeth Slagle. I'm the incoming Vice Chair for the Minnesota section of the American College of Obstetricians and Gynecologists, and I represent nearly 1,000 providers of women's health care in the state of Minnesota, and we strongly support House File 520. I'm on call today, so hopefully I won't have any interruptions, and I'll try to keep it brief, as Dr. Representative Morrison did a great job of overviewing and highlighting the importance of this legislation. But let me just highlight again on the urgency. Through this committee and other testimonies have really identified the increasing mortality rate for women in the United States and in the state of Minnesota, as Dr. Morrison already pointed out. And so it is really imperative for women to be able to decide when and if they want to get pregnant, and to assume the risk of pregnancy that goes along with that. For women of color, Indigenous women, the risk of death because of pregnancy is 3 times that of white women, and this is regardless of their education or their socioeconomic status. Our patients are getting sicker and at younger ages for reasons that we don't entirely understand, but are likely very multifactorial. My patients specifically are scared. They're scared to get pregnant. They're scared of unintended pregnancies and what that means to their overall health, especially as women are trying to optimize their health and may have an unintended pregnancy. We know that access to the right contraception works. Since the Affordable Care Act was enacted, improving access to contraception without cost sharing has dropped the unintended pregnancy rate in Minnesota from 48% to 38%, an improvement that's been seen throughout all age groups. Women no longer have to spend hundreds of dollars a year on birth control pills, or $1,000 on an intrauterine device or IUD. They no longer have to settle for an affordable option that may give them worse side effects than other options. Access to contraception means women can optimize their health and determine the right space for their pregnancies. Planned pregnancies result in healthier outcomes for moms and babies, full-term deliveries, healthy birth weights, high-quality prenatal care, and optimizing outcomes for complicated pregnancies. And as Dr. Morrison also mentioned, I want to emphasize that hormonal contraception is widely used for purposes other than preventing pregnancies, for chronic and debilitating pelvic pain, severe anemia, and uterine cancer prevention and treatment, just to name a few. With the ACA guarantees being threatened, the security of Minnesota women becomes even more vital for their personal well-being and for that of their families and the communities. Every woman, regardless of her insurer, her employer, or income, should have easy, affordable access to the right contraception for her at the right time. The lives and the health of Minnesota women depends on this. And I would just also like to highlight and finish by saying that practicing before the Affordable Care Act and having contraception as an essential health benefit and practicing after, it's a stark difference. And our women are doing better since the Affordable Care Act and for this essential health protection.
All right. Well, thank you, Dr. Slagle. And I would just ask you, it probably goes without saying that access to birth control reduces abortion.
Absolutely.
Is that accurate?
We've known that for years. That's always been what the statistics have always proven that. Most of the time when women undergo an abortion, it's not something that they choose and it's a result of an unintended pregnancy. If they'd had access to contraception, that wouldn't be an issue.
All right. Well, thank you so much. It just occurs to me that this is something that all members should be able to get behind, those who are opposed to abortion and those who believe that it should be a woman's choice. Everyone probably can get behind, I hope, the idea that women should be able to prevent unintended pregnancies. And
absolutely. Talking about healthy families.
Thank you, Dr. Slagle.
Thank you.
Other questions? All right, not seeing any. Representative Morrison, would you like to have the final word before we lay the bill over?
Well, thank you, Madam Chair. I just want to reiterate that birth control is basic preventive health care, and I urge everyone to support this bill to protect and expand access to contraception in Minnesota. Thank you for the opportunity.
All right, well, thank you very much. And House File 520, as amended, is laid over for possible inclusion in the finance bill. All right, we have House File 1516, and this is Representative Schultz, and Representative Schultz is going to move that House File 1516 be laid over for possible inclusion in the finance bill. Representative Schultz.
Thank you, Chair Liebling and members. House File 1516 is a bill to address the high cost of biosimilars. Biosimilars of medication, they're often very, very expensive. People, for example, with rheumatoid arthritis may be taking a biologic. And this bill increases competition between biosimilars, which you can think of like a generic drug, and biologics. So it makes it easier to be reimbursed for biosimilars and hopefully increase competition between biologics and biosimilars. This is a bill I worked on closely with a constituent of mine who's here to testify, and a researcher from the Mayo Clinic, I think, is also here to testify to talk more about the bill and to help answer questions. But I encourage your support and thank you for hearing the bill. And I'll turn to, I think the first testifier is David Spurl.
Yes, thank you, Representative Schultz. Mr. Spurl, welcome. Please introduce yourself and go ahead with your testimony.
Thank you, Chair Liebling and committee members for this opportunity to testify. My name is David Spurl. I'm a pharmacist at Essentia Health and a constituent of Representative Schultz's, and I'm here with my colleagues Molly Skifstad and Roseanne Hines. Today, we're asking for your support of House File 1516, a bill that allows providers to prescribe biosimilar products in a manner that focuses on patient safety and helps drive down the costs of prescription medications. Biosimilars are a newer class of medications that have no difference in safety, purity, or effectiveness when compared to their brand biologic counterparts. These new biosimilar medications offer significant opportunity to drive down costs, much like generic medications have done for years. Unfortunately, the current system set up by medical and pharmacy benefit managers and pharmaceutical industry brand manufacturers has limited the ability for patients to benefit from these new medications due to rebate traps and other anti-competitive tactics. Most concerning, the current structure also causes safety concerns for some of our most at-risk patients, those with cancer and debilitating chronic diseases like rheumatoid arthritis and gastrointestinal diseases like Representative Schultz alluded to. And as we see every day in our practice, caring for patients, and as discussed by the Institute of Safe Medication Practices, there are various safety concerns regarding the current payer-driven system for prescribing and dispensing biosimilar medications. For example, in order to satisfy the different payer requirements, a healthcare provider has to devote significant resources to maintain complex inventory of multiple versions of these equivalent medications. By requiring coverage parity, insurance coverage parity of all biosimilar medications, this bill will alleviate these risks by allowing doctors and patients to choose the medication that's safest and brings optimal value for the patient. In addition to these safety implications, biological medications are the most significant driver of prescription drug spending in the US and have been cited to account for almost 40% of total prescription drug spending. Solution to reducing the spending is available by creating greater competition and reducing PBM anti-competitive tactics, which this bill would accomplish without taking away any of the tools for overall formulary management that are available to drive down costs overall as well. This year is slated to be another year of exponential growth in biosimilar medications, which is why we believe it's important today to continue these efforts to facilitate the use of biosimilar medications in a manner that focuses on safety and lowering costs. For these reasons, Essentia Health looks forward to working with this committee and other stakeholders to ensure House File 1516 addresses the safety concerns discussed today and allows providers to prescribe the most safe and affordable medications for patients. Thank you so much for your time.
All right. Well, thank you very much, Mr. Spurl. And it'd be great if you could stay with us for a bit in case there are questions. Next testifier, Brett Michelin. Welcome.
Thank you, Madam Chair, members. My name is Brett Michelin. I'm with the Association for Accessible Medicines, and AAM represents the manufacturers of generic and biosimilar medications. And I want to say this in as light of terms as possible because we are still currently opposed to this bill. We appreciate the work from both Essentia and the author on this. And I think we really do want to get to a place where we can foster that type of competition because, as was noted earlier, biosimilars really do have the potential of bringing the highest amount of cost savings, nearly $100 billion by 2024, into the healthcare market. And so that's our goal, is to create a better atmosphere. Unfortunately, we believe that the way that this bill is currently drafted is it's simply moving the decision of what is going to be covered from the PBM and insurer side to the provider side. And while typically that sounds like, well, that's exactly right, we want to be able to foster a better competitive marketplace where the biosimilar is going to get picked up more often. There's studies out there that have shown that that's not necessarily the case in some of the large facilities of the provider networks where they do have the ability right now to choose a biosimilar over a biologic. And so that's kind of the narrow needle that we are trying to thread. Absolutely appreciate, again, the work from last year to this year and look forward to continuing to work on it. Thank you.
All right, thank you. Dan Andreessen.
Thank you, Madam Chair, members of the committee. Again, Dan Andreessen with the Minnesota Council of Health Plans. Thank you for the opportunity to share our thoughts on House File 1516. We've had several meetings with Representative Schultz on this bill as well, and look forward to continuing the dialogue and attempt to avoid any unintended consequences. We share the intent to foster expanded use of biosimilars in the market, which are generic versions of biologics, when biosimilars may be more affordable in the best interest of our members. Biologic medications used to treat arthritis, cancer, and other ailments are some of the most expensive drugs in the market, leaving patients with a challenging decision to pay or not pay for these life-altering medications. The continued addition of biosimilars are widely expected to bring down consumer costs in instances where prescribing a biosimilar is medically appropriate. However, it's unclear whether the language in Section 1, Subdivision 2 will accomplish the goal of increasing the more affordable and equally safe biosimilars. We're concerned about the potential scenario of a provider bulk purchasing a biologic and carriers being required under this legislation to cover that drug, which may end up being more expensive for consumers. Given the short shelf life of these medications, they have to be used quickly before they expire. Biologics are not like other drugs that can be bulk purchased and sit around for long periods of time. Once you have a biologic sitting in your warehouse, you need to dispense them. Our read of the language is that a health carrier would be required to cover and not limit access to any biologic or biosimilar chosen by the provider in this situation. There are times when a specific drug may not be in the financial best interest of a patient when there's a cheaper alternative. And lastly, we would urge adding state public programs and CGIP in the bill to ensure that all Minnesotans are treated the same way as they would be in the commercial market. This issue is very complex, and we are committed to continue working with Representative Schultz and proponents so we can avoid any unintended consequences. Thank you.
All right, thank you, Mr. Andreessen. Michelle Mack, welcome. Please introduce yourself.
Good afternoon, Chair Liebling and members of the committee. My name is Michelle Mack, and I'm a director at the Pharmaceutical Care Management Association, PCMA. PCMA represents America's PBMs, or pharmacy benefit managers. PBMs are engaged by clients to manage pharmacy benefits pursuant to health insurance benefits and contracts. PBMs only manage pharmacy benefits that occur in the prescription drug benefit, so any prescription drugs given in a hospital setting are not covered under the prescription drug benefit, but under the medical insurance plan. I'm here today to provide our perspective and respectively testify in opposition of House File 1516. We applaud Representative Schultz for her stated goal to use this legislation to increase the use of biosimilars and thus decrease the cost for consumers. Increasing competition in the evolving market can surely lead to lower costs to Minnesotans. Years ago, the PBMs were instrumental in supporting the federal law that was enacted to grant the Food and Drug Administration the ability to create a framework under which biosimilars are approved. Today, still, we strongly support the increase in development and use of these drugs. Unfortunately, the sponsor's goal of increasing the use of biosimilars and lowering costs to consumers may not be achieved. House File 1516 expressly limits the PBM tools, such as formulary development and management, specific to biosimilars, which effectively is hamstringing PBMs and plans where these tools are needed the most. The bill creates an open formulary for these drugs. And this will only lead to the increased cost because there will be no incentive for the manufacturers of these drugs to compete on price. In addition to our concerns that the cost savings may not be the result of the legislation, we also have a few questions and concerns for the bill proponents, which is there's no requirement that the health system purchase these drugs at the lowest net cost. There's been discussion about this saving the patient money, but we don't see language in the bill that references this. Relative to Mr. Andreessen's question is why the public health care programs and the state employee group insurance plan are exempted from the bill. Finally, we appreciate the study language to evaluate the impact of the legislation after the bill has become law, but we would recommend, however, that it might make more sense to conduct this research and analysis on the front end to determine the intended and unintended consequences on all stakeholders impacted by the bill. Thank you, and I appreciate the committee's time and attention to our concerns, and am available for questions.
All right, thank you. Eric Tichy, I don't know if I'm saying your name right. Welcome.
That's close enough, Madam Chair. Thank you very much, and thank you, committee members, for hearing me here today. I'm really pleased to see that there's such consensus on the value of...
One moment, though. Could you please say your name? And then also tell us
Eric,
who you are.
Yes.
As you get started. Thank you.
Certainly. My name is Eric Tichy. I'm a vice chair of supply chain at Mayo Clinic, and I am a pharmacist by training. I'm very pleased to see that there's such consensus around the ability of biosimilars to drive cost savings in the U.S. and for the citizens of Minnesota. And really what we're trying to do is ensure that biosimilars function in the marketplace very similar to generic drugs. And the sooner that we can achieve that goal, the more quickly that we'll be able to realize these savings for the citizens of this great state. With generic drugs, the PBMs don't dictate the specific version of a generic drug that we use in our practice, whether it's in a pharmacy or in a hospital. And that's really what this legislation is aimed to achieve, is to have parity of coverage with biosimilar drugs so that we can smooth the process for providers prescribing them to our patients and for patients being able to access them. At Mayo Clinic, we believe so strongly in this. We have also taken a biosimilar first approach for our health plan. We are the largest employer and insurance provider in the state of Minnesota, except for the state itself from the insurance provider standpoint. And we cover biosimilars at parity with our own health plan, so that if one of our members was to receive care at Essentia, then Essentia would be able to choose the biosimilar medication. And we really ask for the same. In practice, what we've seen is that most PBMs do cover these at parity. However, it only takes a handful to not do that, and it really creates a lot of operational challenges for our providers. And we don't want to create so many problems for our providers that they say, you know what, I'm not dealing with this. I'd rather just order the brand name product and be done with it. So that's really the reason why and the rationale for how this would drive savings. So thank you for your time, and I'd be happy to answer any questions the committee has.
All right, Mr. Tichy, thank you. Representative Schultz, do you want to, Mr. Tishy's the last of our scheduled testifiers. So do you want to respond, and then we'll see if there are questions from members?
Thank you, Chair Liebling, and to my testifiers. Thank you for your comments. I appreciate that input. I am making sure that we can acquire the drugs at the lowest cost. So I will be looking at an amendment potentially to add an incentive to choose the biosimilars that are the lowest wholesale cost and pass on those savings to consumers. When we talk about regulating pharmaceutical markets, it's very complex to get it right so we don't create the wrong type of incentives. But I'll just say that, biological medications, we in the US spend over $100 billion on biologics, and only about less than 3% are on biosimilars. So it's the biologics really dominate in the US, and we're not seeing a lot of take up of biosimilars, even though they're much, much cheaper. In Europe, there are over 45 biosimilars that have been launched or more, and they have discounts of up to 70%. So we hope we can replicate that with increased competition and provide incentives to providers and for patients to select the lower cost biosimilar and drive down the cost of our prescription drugs, which have really escalated the last 10 years, our spending on prescription drugs, and it's going to continue if we don't take action. So I urge members to consider supporting this bill, and I look forward to working with all the testifiers in the future.
All right, thank you, Representative Schultz. Are there questions from members? All right, not seeing any. So Representative Bierman, you look like you're going to ask a question. Yes, I see your hand now. Go ahead, please.
Thank you, Madam Chair. This is a question for Rep. Schultz, or maybe anybody she wants to delegate it to. Is so that variance, that huge variance between the biosimilars purchases in Europe versus here, what in the market is making that happen? Why are they so limited in the United States?
Representative Schultz?
Oh, that's a complicated answer, but there's something called rebates and discounts for medications, and right now some of the PBMs will add a biologic to the formulary and cover the biologic because they're getting a significant rebate, and that there's no transparency in that information, and that's not always passed on to consumers or to providers. And when providers like hospitals have to carry multiple biologics, it's really expensive for them because they have to deal with multiple payers, and they all have different biologics on their formulary. But it's really about these manufacturer rebates, and they call this the rebate trap. So we really need more transparency and to make sure any rebates are passed on to consumers, and that we can encourage biosimilars by removing those barriers, which are not. That's not true in Europe. So they have much more regulation and transparency about that pricing and rebate structure and discounts.
And
Madam Chair, so
Representative Bierman,
a follow-up, please. Thank you. So this bill, this plan with the biosimilars, is this sort of a way forward with the rest of the drug market here in the United States as well? Because I know there's so much of the cost wrapped into rebates that the whole rebate system we have here keeps prices inflated, but consumers don't see that when they go in and get their drug for $15.
Well, this is a good, I'm sorry.
Representative Schultz.
Chair Liebling, Representative Bierman, this is a good pilot of that to see if we can increase transparency and see what happens in the market when we reduce some of those barriers, and to see if we could expand it outside of the biologic biosimilar market.
Okay, and I wonder, Mr. Tishy looks like he might want to add something to that. Mr. Tishy?
Yes, thank you, Madam Chair. I'd love to answer this question. One is Europe has had a process for a little bit longer than the U.S., so that's part of why they have more. Another is that there's a lot of lawsuits that have slowed down the access of biosimilars in the U.S. as far as patents. So that's also been a major delay. And then I think your point about the rebates is very important, because when I can choose the least costly product, I can reduce the price at the pump rather than, a rebate that sort of goes to a health plan that gets distributed in many different ways that's not transparent. So that to me is the power of reducing the price at the purchasing site.
All right, thank you. Representative Demuth.
Thank you, Madam Chair. And to the bill author, thank you, Representative Schultz, for bringing this forward. I understand that the intent is a cost-saving method, or just basically a cost savings. Why would we be exempting those public programs and the CGIP? And I know we've heard it from the testifiers, but why would we be doing that?
Representative Schultz.
Chair Liebling and Representative Demuth, thank you for that question. So they were initially included in the bill, and then we tried to get a fiscal note, and some of that information is proprietary of what sort of discounts the state or those we contract with get. And so it would have been very difficult to get a fiscal note on this bill if we included them. What I'm hoping to, with the study language that is included, I'm hoping we can evaluate the public programs and their costs with biosimilars and biologics compared to the commercial market, and see what happens. What I'm guessing, I'm taking an educated guess that the market, the competition will decrease the cost of biosimilars and biologics, and that the state will benefit from that decrease from that competition between biosimilars and biologics.
Representative Dameth.
Thank you, Madam Chair. Just one follow-up then. As you mentioned that study, again, I heard from a testifier, but I also agree, wouldn't it be better to do that study up front before we actually put this in rather than after and have the full information?
Representative Schultz.
Thank you, Chair Liebling and Representative Dameth. We really need to make sure we're applying this language. So we're going to study the impact of passing this bill and looking to see when we remove those barriers, do we see reduced prices and savings? And so we want to study that. So studying it now, we already have a lot of information now about the really high cost of biologics, and we're not taking up biosimilars. So we've identified the problem. We have information on the cost of biologics, which is extremely high. And we want to implement this language to see the effect of the language and study it after it's implemented to see if we can actually bring down the prices of both biologics and biosimilars.
All right, I'm going to take a final question from Representative Quam, and then we're going to lay the bill over. And members, I've been informed that the speaker does want us to recess at 4:30 and come back at 6. So we will be doing that, but I'd like to get Representative Feist's bill in quickly if we can before we do recess. So Representative Quam.
Thank you. Since this bill is being laid over, it'd be nice to have the committee get the information if there are any other states that are trying similar things or any program and pilot programs doing this. And with that additional time, we should really get that fiscal note so that it's uniform. And yes, thank you, Madam Chair.
Thank you, Representative Quam. So with that, the bill is laid over. House File 1516 is laid over for possible inclusion in the finance bill. So Representative Huot had the next bill, but with your permission, Representative Huot, I'm going to go to Representative Feist, if that's okay. Tell me if you're all right with that.
I can't object, so I'm going to have trouble with tonight's meeting, but go ahead.
Oh, you are? Oh, dear.
I have a referee commitment tonight, so.
Oh, Representative Feist, are you able to wait and come back at 6?
Madam Chair, will it overlap with the DFL caucus meetings, or will it be after? You said 6 o'clock?
Yeah, this is a direction from the speaker because notwithstanding that the Republicans took a lot of time on the floor, they have their caucus and we're being asked to stop for their caucus. So that's all I can really tell you.
Madam Chair, that works just fine for me.
All right, so we'll go to Representative Huot. Sorry, Representative Feist. Okay, Representative Huot moves that House File 1372 be before the committee to be laid over for possible inclusion in the finance bill. Representative Huot.
Thank you, Madam Chair, and thank you, Representative Feist, for your willingness to work with me. I'll go quickly. This bill funds our regions, our EMS regions that have been here since 1985. I had a lot more prepared, but I know we got to get going here. So I just want you to know that the regions are the backbone of EMS. You don't see them, you'll never hear from them, but they're the ones that build the EMS system in each of our own regions. There's 8 of them. The problem with the regions recently is they get a lot of their funding from seatbelt fines. Well, guess what? Minnesota's wearing their seatbelts and their fines are cutting down, and now we have to look at other options for them. Especially during COVID, the regions have really shined. Other states had mask problems. We were able to at least get masks to our ERs and to our first responders until the feds came in. They set up testing stations. They're now doing vaccination stations. They also did a lot with EMS training. We can see a direct correlation between EMS recruitment and retention of when we funded them back in '89 at the full amount to today, where we've seen a drastic cut in EMTs throughout the rural area. I believe this is a direct correlation of us losing our EMTs in rural Minnesota. So I'm asking members to please consider supporting the regions and let's try to fund them. I have a testifier here, Mr. Griffin. Madam Chair?
Yes, so Mr. Griffin, welcome.
Thank you, Chair Liebling. And again, my name is Mark Griffith. I'm the director for the South Central EMS region based in Eagle Lake, Minnesota, just outside of Mankato. Our region comprises 9 counties, kind of north up to Sibley County and then down to the Iowa border, including Martin County and Faribault County. As Representative Huot had stated, you know, a lot of our funding does come from seatbelt fines, and a lot of the programs that that my counterparts and I have used to address and fill gaps in the EMS systems have been largely come out of that funding. We are here today in full support of House File 1372. As Representative Huot also alluded to, that one of the, you know, even though the regions have statutory obligations, a lot of those statutory obligations can be rolled into training, both public and EMS. COVID, you know, training was difficult enough for volunteer responders especially, and each of my counterparts addresses training different, kind of based on their regional resources. In our region, we've got a lot of rural volunteers, and it was difficult enough to train them before a pandemic. During a pandemic, when we spent 2 months trying to teach how to relearn what we did in the field, that was extraordinarily difficult, and that's an evolving situation. We continue to change our approaches to patient care. Again, a lot of that training, a lot of the initiatives to keep our responders in the field and keep them healthy come from that seatbelt money. Representative Huot stated we have assisted in pushing out 3 PPE distributions to our region since the start of the COVID, and with no compensation on that end. We did it because it needed to be done, and it was the right thing to do. We do team up. We partner with our Southwest and our Southeast partners to get information out to the public and to our providers during this pandemic, and we enjoy the work that we do. We are just asking for some additional support to make sure that myself and my counterparts can continue to do that work to the quality that you and the people of Minnesota expect.
All right, thank you, Mr. Griffith. We appreciate your testimony. Representative Huot, I'm not seeing any questions, so any final word before we lay the bill over?
Madam Chair, I appreciate you hearing the bill quickly, and committee members, I would appreciate your support on this bill. Thank you, Madam Chair.
All right, thank you, Representative Huot. I'm sorry to have to compress your time. Quite unexpected, since I thought everything would be moved back. So members, we're going to be in recess. I'm expecting, I've been told until 6, but I would just say, watch your email and we'll confirm the restart time here, because, you know, making sure that everything's accounted for this evening. And honestly, we don't have that much left on the agenda, so it's really unfortunate we couldn't have just finished here this evening. I'm sure we wouldn't have even been here till 5, but anyway, so we will see you back at 6 o'clock or thereabout. And so we are in recess. Thank you.